Welcome everyone to the research symposium today. I'm Becky. I'm a research assistant in the School of Social Work. I'm also a program coordinator for Build Exido. My pronouns are she or they, and I'll be your moderator today. And it's my job to keep the flow of presentations going smoothly. I'll introduce everyone who's presenting. I will try my hardest to correctly pronounce the titles of people's research projects, but then you'll get to hear lots more about them from the presenters. So the structure of the oral presentations today are going to be in 15-minute blocks, about 5 to 10 minutes for the presentation and 5 minutes for some Q&A and a couple of minutes for turning over presenters. So we really encourage you to ask some thoughtful questions and be curious about your fellow students' research. Even if you're not quite sure what to ask, you could always say, tell me more about your research. What is something that you didn't get to present about? And then we'll help a little bit too, just kind of seed some of those questions. You can find the schedule for the presentations today in the packet. And also, I think that there's a QR code on one of these somewhere, if you wanted to look at it online. And then there's an event site as well on this. Jen Lindwall is our AV person. Jen Lindwall is the new
remember what it's called?
Yeah,
Associate Director of CIMR.
Associate Director of CIMR, which is really rad. And is going to help us also with organizing presentations and staying on track to date. And then folks who are joining us in the Zoom world and are on chat, if you want to ask questions of the people presenting, you can also do that. You can hop between rooms and go see other presentations. We just asked you to do it after a Q&A has wrapped up and while presenters are changing. The room is mic'd, so keep chatter to a minimum. And without further ado, I'd like to welcome Jonathan Palacios. Jonathan, I'm going to say a little bit about your research mentor is Dr. Osborne, and the presentation today is effects of metformin on chronic binge-like ethanol drinking and AMPK signaling in inbred high drinking in the dark line 1 mice.
Good morning, everyone. My name is Jonathan Palacios, and I am part of the Osborne, as previously mentioned, where we focused on the neurological mechanisms of addiction and substance use disorders. And today I'm going to be talking about the effects of metformin on two things. First, chronic binge-like ethanol drinking and AMPK signaling in this line of mice that has been bred to drink to intoxication. But first, let's go over some background. So we know that AMPK is a protein kinase that is a cellular energy regulator. It's found in many body tissues, including the nucleus accumbens, which is our region of interest. We also know that our previous studies have shown that ethanol and cocaine have shown to decrease the phosphorylated form of AMPK, which is known as AMPK. And it has done that in many brain regions that are associated with motivated behaviors. Also, metformin, it's an AMPK activator. Currently, it's heavily prescribed for type 2 diabetes. But we know that it enhances cellular energy metabolism through various mechanisms. So now we want to answer the questions: does metformin affect chronic alcohol consumption and brain AMPK activity? So in order to do that, first, we did a study where we wanted to determine the effects of metformin on chronic binge-like ethanol drinking. So in order to do that, we did a drinking in the dark paradigm, where basically mice received 20% ethanol 3 hours after the lights were off, and they receive access to ethanol for 2 hours on days 1 to 3 and for 4 hours on day 4. They did that for 5 weeks, and on week 5, they received the treatment, which was either vehicle or metformin, and they received an injection 30 minutes prior to ethanol access. So about 2.5 hours after the lights were off. And at the end of day 4, their brains were collected for the second part of the study, which is the AMPK and PMPK quantification. So we wanted to see whether metformin affected AMPK signaling. So we performed Western blotting, where first the brains were sliced into tiny pieces, and then the protein was extracted from the nucleus accumbens, which you can see circled in there. And after that, the tissue was homogenized, where we broke the cells in order to extract the protein from them, so that we can then load equal amounts of protein into a gel on step 3 in order to separate the protein by sizes. And then we transferred the proteins into a membrane where it was immobilized, so we could perform further quantification. But in order to do that, we first needed to add a primary antibody and a secondary antibody. Basically, the primary antibody binded to the protein of interest, and then the secondary antibody binded to the primary antibody. And at the end, we added a substrate that binded to the secondary antibody that allowed us to visualize the protein. And then after that, we could do the quantification. So now let's talk about the results from the chronic binge-like drinking. So as you can see on the top, we have the ethanol group, days 1 through 4. On the y-axis, we have ethanol intake, and on the x-axis, we have the treatment group, where the vehicle blue bar and the metformin is the red bar. So as you can see, metformin reduced binge-like drinking on days 2 and 4. And then on the bottom, we have the water intake. On the y-axis, water intake, x-axis, treatment group, same color scheme. And as we expected, there wasn't any significant difference in water intake. So we can see that metformin only reduced ethanol intake and not water intake. And then from the Western blotting, we have the PMPK and AMPK expression. On the left, we have the PMPK intensity, and on the middle, we have AMPK intensity. And then the right graph is the ratio of PMPK to AMPK. And as we can see on the y-axis, each protein's intensity, and on the x-axis is the fluid groups, which we used either water or ethanol. And the bars represent the treatment groups, which we have vehicle and metformin. And as we saw, there is no significant effect of metformin on any of these protein levels. So, which leads us to conclude that metformin reduced binge-like drinking on IHD1 mice. It did so without altering AMPK levels. So as we saw, neither chronic binge-like drinking nor had any effects on AMPK and PMPK signaling or levels in the nucleus accumbens. And lastly, some limitations. So for this study, we only used 1 dose of metformin, which was the 150 milligrams per kilograms. And we also only used binge-like drinking tomorrow to test the effects of ethanol and metformin on AMPK and PMPK signaling. So maybe they're more effective, or metformin works most effectively in alcohol-dependent mice. And lastly, we know that metformin acts through many mechanisms, so maybe it reduces drinking through other pathways. Well, thank you to the Osborne Lab members and to the URISE program. Does anyone have any questions?
do. And I'm sorry if I missed this when I was helping with tech at the beginning. Why is it in the dark?
Yeah, so mice are more active at night.
Okay.
So that's why the whole procedure is after the lights are
Not
on.
in the dark. Okay.
Yeah.
Okay, then I have another question, since that was a simple answer. What is an alcohol dependent mice? Like, how does that work?
So basically, there's a different test to determine whether a mice is alcohol dependent, and that has to do with withdrawal symptoms and remission state, which we didn't test for this study.
What are there, so I'm making an assumption that this is research that you're doing with mice that may have impacts for humans. Am I making a correct leap there? Okay. Yeah, so what's the next step for a study like this? Do you have an idea?
Yeah, so, well, there are many possible steps from now. We can either test different brain regions, or we can test different pathways which metformin adds, or also we can test different drugs, because metformin has been repurposed for this to test whether it affects ethanol consumption. So maybe we can repurpose other drugs as well. Thank you.
Stuff annoying up here.
Yeah.
Okay, that's great.
Good.
You can have it open and then I'll go here. Yeah. So this will advance as you. Yeah, you can. And you can make that bigger. Yeah, you can. Do there's a spot, or you can hear. And yeah, this one. Yeah, and then this, and then the camera will follow you wherever you go. And I have I'm gonna give you a 30-second warning, careful. Heads up.
Yourself? Yeah, okay. You can do it. Okay, great.
Okay, so hello everyone. My name is Galilea Estrada Sanchez. It's my third year in my undergrad, and I'm part of the Listo School Readiness Lab, and my PI is Dr. Peterson. And the title of my presentation today is Kinder Coach Ready Coaching Appointments in Primary Care Design for and by Latino families. So starting off, this is an image of people who are in my lab. We're all bilingual Latina women, and I'm really thankful to be part of this lab. And as for an introduction, we know that low-income and minority children are often behind compared to their affluent peers, known as the SR gap, school readiness gap. And Latino families face many barriers, as past research has shown limited SR knowledge. The current study is based on feedback from in-depth interviews with Latino families, where we found out through the pilot study what Latino families would like to gain from the coaching sessions and different ways that they would be able to learn. And then, so children who succeed in our experience school readiness, succeed academically, are healthy and lead productive lives. And through this figure 1, it's a visual of the different education framework that the school readiness study is based on cognitive and early literacy and math skills. So we know that through the school education framework, where they can learn colors, shapes, and reading, writing, and through learning about that, pediatric doctors are trusted partners and are well positioned to provide SR support. We are able to identify the different ways that parents can be the main teachers through developing their cultural identity and different ways that they can teach and model the learning that they learn through the SR coaching. And this is a visual of the social ecological model that bases the interpersonal level of the child, which we know that the children living in poverty experience fewer pre-literacy and activities, which is known as the 30 million word gap. And then at the organizational level, low income and minority parents face financial, informational, and cultural barriers. And for the objectives, this project aims to reduce the SR gap among Latino children by providing early, personalized, and culturally responsive coaching of parents with preschool age children to increase early math literacy skills, parent confidence, and promoting SR connection to community resources. And the objectives are to 1, report practicing SR behaviors, and 2, less likely to report barriers to preparing their child for school. And the methods of the study is we aim to recruit 300 participants of 3 to 4-year-old children. The first coaching session is where we go over consent, pre-assessment of the parent and child care by getting information about what different areas the parent might have limited knowledge in, and about providing SR at home. And 3 months after the SR coaching intervention will be the post-assessment with the follow-up, where we learn more goals and different areas that the parent still has concerns in, or different things that they would like to get more assistance in. And the participants are again 3 to 4-year-old Latino children on Medicaid, and are part of our patients at the 2 pediatric clinics. And I have a picture of the Bergans screening that is used by the community health worker to assess the child's cognitive and early literacy and math skills. And this is another image of the coaching sessions. It's 1 hour with the bilingual, bicultural community health worker, where they assess the parent and the child. The parent intervention is modeled by parent modeling, where they receive resources and different tools that they can be used at home. And here we have something from the parent had mentioned that they had no idea what they did or did not know, and what they were doing to help prepare their child for school. And after the they knew how they could help and practice these things like colors, counting at home, and how they can help with their children's reading. And this is an image of the OHSU dorm Rutgers Pediatrics Bethany Village Clinic, where we have a clinic appointment room that was converted into a coaching room. And we have the whiteboard, which is used by the community health worker to assess the parent, and where the parent can identify things that they already do at home, things that they want to work on, and things that the child already does or doesn't do. And there we have the Bergans assessment. And my role in this beautiful lab is to do REDCap training and data entry. And I created a preschool map, which I will show in the next slide. It's an interactive map that can help the community health workers identify preschools that are close to their area. I go and observe coaching, as well as we'll be doing fidelity checks on the community health workers to make sure that there's infrared reliability within each clinic, as well as bringing coaching supplies to the different clinics and community outreach with visiting local libraries and community action to get resources for the families. And here's the visual of the preschool map, along with the different organizations that me and the other community health workers have visited for resources, and along with going to the libraries. And for preliminary results, this is a diagram I created for the Dornbreckers Bethany Village Coaching Clinic. And we have total patients assessed. So I divided it by pre-assessment and referral to enrollment. And we have 21 patients at this clinic assessed currently, along with total referrals to resources with 6 patients, and 5 patients have been enrolled in preschool, which is very amazing. And along with how many families the community health worker called and who declined, and due to that being declined was because they did not meet inclusion criteria because they were no longer included. And limitations and future directions is it's an ongoing 2-year study. The Kindergarten Ready coaching mission is to ensure that all patients are ready and prepared to learn in kindergarten. If coaching is effective in increasing child skills and parent confidence, it may be tailored to other populations. And lastly, I'd like to acknowledge all the funders and URISE, especially Dr. Peterson and Maya, for being so supportive, and even and McNair, because I really wouldn't be here without all of their support. References and any questions?
So for children who are fluency in a different language, you need to have skills in that language, but they still three times behind English specifically.
So technically, through learning about it before, there used to be with bilingual children, there used to be often that there was like speech delay because it would be assessed only for their amount of words they knew in English, which is I believe 50 words. But now we've learned that like bicultural and bilingual children are actually like ahead in with ever how many words they know in English and Spanish combined, that would be where we are at.
Can you talk more about what CAP training was?
Oh yeah, so for the data analysis, the pre and post test will be compared through data entry into REDCap. So that's where I would be trained on how to like make sure that there's no missing data on REDCap, and along with the whiteboard that I mentioned in the earlier slide, the community health worker can take a picture of that and just upload it to REDCap and then put that information for more accessibility with the parent and getting that information.
What's been your favorite part of this research?
Yeah, so I forgot to mention, but being part of this research as a first generation student, and especially as coming from Latino parents, being able to watch the coaching sessions, it's been really, it resonates with me the whole study, and I feel like just being there and watching the family that I like, there's so many similarities, and there's continued to be a necessity for programs like this, and it's really important. And especially for me, I didn't go to preschool, and I came into kindergarten not speaking English, so like I truly believe in the study, and I'm grateful to have the opportunity to be working alongside Dr. Peterson and Maya and everybody in the lab.
In the ecological model you showed, you talked about kind of the child level, the parent level. In your opinion, what do you think some of the biggest barriers are that parents face that you're addressing through the coaching?
Yeah, so I think the biggest barriers that is being addressed to the coaching is the limited knowledge about what SR learning is and the different things that parents are aware. Latino parents, oftentimes the children come in with high social emotional skills, but lack the cognitive and early literacy and math skills. So that's really what the parents are unaware of, what they don't and what they do know. So through the coaching sessions, the community health workers are able to identify what the child has limited knowledge in, and how that can be modeled to the parent, and how they can learn how to like, identify the shapes or colors or the sizes of different like objects. And through that modeling and empowering, the parent can do that at home. Any other questions?
Thank you so much. Oh yeah, next week. Yeah. Yeah, we got 5 minutes for the switch up. Come on, yeah. We can get you prepped. Yeah. And
Do you need any notes for you?
okay, yeah, I have it here. Okay. Okay. I'm gonna do, let's put it in slideshow mode. Intro you, or you can enter this.
I got it.
You got it. Okay. You can do the advance, or you can do. Yeah, we're gonna wait, mostly because like if people are coming in to see people at certain times and things like that. I'm just, yeah, do whatever you need to do. Yep. I think it's a quick snack or a drink. We'll start up again at 10:30. Oh, yeah, no worries. Thank you. Thank you. Yeah. What are you doing? Yeah. Research. You know, yeah, so. Yeah. I don't think,
Just like seeing things from the line. You can just take those. Right now and just get on in.
yeah. Yeah, I think it's a good idea also because. I don't know. It's electric and I can hear you. We don't do you have to read the programs.
Well, I don't know, because we also programs don't have summer program,
Yeah, okay.
you know.
So we would be guys and we would be in my house.
Okay. Let's dream, the dream will be done.
Yeah.
We might even.
Oh, okay. This must be. Spring's the best.
Yeah, okay.
So tempted to ask everyone how summer went. How was summer? Summer okay? Did you get out? Yeah, yeah. Did you get out, go swimming, go to the river, go hiking? Yeah.
Some things happen.
Some things happen.
Once the sunshine goes away. Be so sad when I see one.
No, I got a sad lamp this last year.
A what?
A sad lamp, the like sunshine lamp.
Ambiance.
Yeah, yeah.
Do you remember?
No, it kind of like sits to the right of my computer and my, like, you can't really look straight at it. And my boyfriend's always like, ah, how can we look at that? I'm like, don't, just have it like
Hit your eyes.
enter your field of vision from the side.
I have a friend who like has one and she like every morning before work, when she works from home, she sits like for 15 minutes and just like it goes like this. And then
Yes.
she starts Jesus helps.
I think it does too, even if it's
The
the
placebo.
placebo, I was just gonna say. I don't
Like,
care.
Yeah.
That's like who cares?
Love a placebo, yeah. Oh, same.
Did you play around with advancing the slides? Okay, you can also use the mouse if you're more comfortable.
There you go. Cool.
All right.
I think the floor is yours.
Okay, cool. And I am going to give you this and this,
Okay,
but I'm not going to cut you off.
okay. Cool, thank you. Okay, hi, my name is Layaal Khellah, and I'm going to be talking today about developing an automated tool that calculates an acoustic metric called PVI from patients with speech disorders post-stroke. And we're going to be looking at two different language disorders, aphasia and apraxia of speech. So I'm going to take you through what those two are. The issue with diagnosing them, PVI, a way to diagnose them, and then how we automated it with the Python scripts. And then finally my conclusion. So aphasia and apraxia of speech. Aphasia is an acquired language disorder. And what that means is that patients post-stroke have difficulty retrieving the word they want to say, because we all have like maps of words we want to say. It's difficult for them to access which one they specifically want to say. But there's no impairment in actually producing the word physically. On the other hand, apraxia of speech is kind of the opposite. They know which word they want to say, so the word retrieval step is okay, but there's a motor planning and production impairment. So translating that word into how they want to physically say it is where the issue is. And being able to diagnose aphasia with apraxia of speech and aphasia without apraxia of speech is pretty difficult because they have several overlapping symptoms. And the gold standard in the field is pretty much a clinician's ear, which is very susceptible to bias. And it's also very time consuming. And so the challenge that our project presents is being able to accurately diagnose aphasia with apraxia of speech and aphasia without apraxia of speech. And so the sample of patients that we had were a sample with and without, but they all had aphasia. And so one way to be able to distinguish between the two is PVI, or the Pairwise Variability Index. I'll probably just refer to it as PVI as I go along. And recent research has suggested that it's pretty good in being able to differentiate between the two. And that's because it takes the difference between two successive vowels and divides by the average duration to normalize for individual speech rate. And the reason it does that is because patients with language disorders typically speak with similar stress levels on the vowels, whereas like me and you, people who don't have their language disorder, will speak with different levels of stress. So the more similar the stress levels of the vowels they pronounce, the more likely it is for them to have aphasia with apraxia of speech. And the formula for PVI is very simple. It's just the difference between the two vowel durations divided by the average. We take the absolute value multiplied by 100. So it's pretty easy to do. The only thing is it's very time consuming in a real world clinical setting. And so my job was to help automate that by developing a couple software scripts to automate it. This is an example of a speech file from one of the patients in our sample. And so they're told to pronounce words that typically have two successive vowels, so like potato, tomato. And so over here, as you can see, we take the two first successive vowel sounds. So the first one, that upside down E, is called a schwa. And the second one is that EI sound. And so what we do is we take the durations of those two, like highlighted in yellow. And this is an example PVI calculation. So 0.127 as shown over here in the yellow. I don't know if you guys can see. 0.154 was the second, and we do that simple PVI calculation. It's pretty straightforward, but automating it was the fun part. So I'm going to show you the Python scripts that I helped write. So there's two. One is called extract and one is called vowels. It'll make sense hopefully why we name them that way as I go forward. So pretty much the first thing we did was we took the audio files along with phonemic transcriptions of what they said. So pretty much just, we put them through something called MFA. It's called the Montreal Forced Aligner. And the best way I like to describe this is if you guys have like Spotify or Apple Music, as the lyrics go on, they move as the audio progresses. So the audio file and the words are aligned. And that's what MFA did, is it aligned the audio file of the patients with a speech disorder and the transcription of what they said. And it outputted this. And so from this, our code extracted exactly what we wanted, hence the name extract, which is just the timestamps of the words here on the left, and then their corresponding vowels, which is referred to as phonemes over here on the right. And the reason we extract just those timestamps is because we want eventually the durations like I said earlier for PVI, the duration of vowel 1, duration of vowel 2. So that was the first part of the code. The second part of the code, vowels.py, this is where the fun part happens and we actually calculate PVI. So this should look a little familiar to the formula I showed you earlier. It's the code version of that PVI formula. I don't know if you guys remember it. This one right over here in the square. This over here is just it written in code, and Python is like pretty nice. You can actually use words. So the first duration minus second duration divided by the average multiplied by 100. And vowels gives us this very pretty table. When I first saw this for the first time, I was so happy because it was like, this was our big moment. The last column is the most interesting column. It's the PVI output. That's what this line produces. And so our whole big question was, how good is our automated tool compared to a human being producing this PVI? And so what we did was an inter-rater reliability test. We used R, and what that did was compared our program to students in the aphasia lab from the Speech and Hearing Sciences department who manually calculated PVI, and the ICC point estimate was 0.738, which means that there was a moderate reliability between the two raters. But the range of moderate reliability is 0.5 to 0.75. So 0.738 is in that upper moderate reliability range. So it was pretty good. And we hope that once this program is going to be used with American data, our lab is in the process of not almost done collecting audio files from patients in the States, because I forgot to mention, but the audio files were given to us from the University of Sydney. So it was Australian patients. And the MFA that Aligner told you about was trained on American English. It's AI trained on American English. So hopefully with patients that speak in American English, we can get a higher reliability. Yeah, I just want to say thank you to the Aphasia Lab and to Robert Gale from OHSU because he was the lead in developing the script, and to Michaela Flegel and Dr. F and everyone at the Aphasia Lab. And if you have any questions?
I have a question. Oh, is this your first time playing with Python code and getting nerdy about that?
So the first class they offer at Portland State is Python, but it's really like introductory, and it's because like, you know, I showed you like they use a lot of words in Python, so it's like really good for an intro programmer. This is the first time I've dived this deep in it, and it's because artificial intelligence is like almost all written in Python in our lab, like dealt with AI. So that's
So you can sort of spit out the code and then you can like check it for what you need it to say.
yeah, it's pretty cool. You get into like debugging, and like that's what we ended up doing was comparing it to them like human being calculation, cross check, which was cool.
Yeah.
Yes.
So being able to diagnose these two, like these together is important. And what is the hope and the like long-term impact on a patient who you're able to maybe, you know, diagnose more easily with this approach?
So the hope is that this like program can be used in a clinical setting so that it can reaffirm, maybe not take the lead in diagnosing, but reaffirm a clinician's diagnosis itself, because it'll speed it up rather than them like taking audio recordings of their patients and performing PVI. And then also being able to tailor their treatment plan a little bit better, because if they have one versus the other, their treatment would differ. Well, thank you. Can I just leave this up here? Yeah. Thank you.
We have another 5 minutes. Is Nancy here? Hey, y'all, I'm gonna do it. I'm gonna intro our next presenter. This is Nancy Ledezma. Is going to present the knowledge of Medicaid expansion to recent and undocumented immigrants among Oregon, Mexican origin Latinos. It's an in-progress study, and please welcome Nancy.
Hi everyone. This is my research project that I've been working on with my team member Grace Parra and my PI Dr. Lloyd Darney. My project is over the knowledge of Medicaid expansion to recent and undocumented immigrants among Oregon Mexican origin Latinos. It is still a work in progress. The reason I am interested in this project is because growing up in a Latino household, I saw my extended family not be able to use medical resources because they were either afraid of their status, fear of public charge, and if they did go, they would have to pay out of pocket. So to start with some background information, what is Medicaid? It is a government-funded health insurance program that covers low-income individuals and families. However, undocumented and recent immigrants are excluded from the federal Medicaid program. Oregon, along with California, Illinois, Massachusetts, New York, and Washington, are just some of the states that have extended some benefits to undocumented immigrants. To continue with more background information, so what is the Healthier Oregon program? To fill this gap, some states use state funds to extend coverage to undocumented and recent immigrants. Oregon passed a legislation to expand Medicaid to adults who do not qualify for full Medicaid via federal rules and qualifying immigration status named Healthier Oregon. This program has two phases. The first phase went into effect last year, July 1st. It extended Medicaid to immigrant adults 19 to 25 and 55 and older. The second phase went into effect this year in July as well, and it extended Medicaid to immigrants of all ages now. And so this is an example of a poster that's being used to promote the program. This also makes clear that it's any age as well as regardless of immigration status. It's also available in a lot of languages. So the objective of my study is to identify if Mexican origin Latinos in Oregon are aware of the Healthy Oregon program, eligibility, and whether barriers to enrollment exist. Since this is a new program, along with the recent policy change, we expect there to be a high number of Latinos who are unaware of the Healthy Oregon program, confused about their eligibility, and have experienced barriers to enrollment. Our team has developed a 19-item survey, which is in Spanish and English. The survey includes topics such as awareness of the program, eligibility requirements, knowledge of the application process, and possible barriers to participation. Recruitment is ongoing, and I'm doing recruitment at the General Consulate of Mexico. Our objective is to identify 500 participants and for them to be self-identifying Latinos over the age of 18. So like I said, I am doing data collection this fall. I will then share my results with the consulate and the Oregon Health Authority in winter of 2023, and then I will begin my manuscript writing in the spring of 2024. Some implications for our study is our results can be used to improve outreach to the Latino community about Healthy Oregon program, as well as future programs to come, and improve access to care for Latinos in Oregon. That is it. The room is open for questions. Thank you. Yeah, I started this month.
How many people are this?
Currently 6, so I still have a ways to go for the 500 goal.
What was the target?
500.
Can you explain, so the only eligibility criteria is Latino and over 18?
Yeah, since the majority of the population that goes to the consulado are Hispanic, so we expect them to be at least 18. They don't have to be Mexican, they can be of any Hispanic descent. But we mostly do get like Hispanic, Mexican people that go to the Mexican consulado. But that's it.
And is the percentage of those folks who are undocumented important or not necessarily?
No, so the target or like the goal of it is, even though the people that are going to the consulate, they may already have papers, but a lot of them don't have papers. They know people that don't have papers. Like the other day I was recruiting, a lady came up to me and said, oh my gosh, when I first started, I couldn't get health insurance, but now it's so crazy that they offer now to all ages. But I know people that don't qualify, or they didn't know that they qualify now. And so hopefully by word of mouth, they can know more about this program.
There's a, I guess follow-up question to that is what are some of the outreach methods?
So when the program first went into effect last year, people got letters, phone calls, and I believe they also advertised it as in flyers. The reason that we're trying to see where the gaps are, because some people may have not received the letter. Some providers don't even know about the program, and so we're trying to see where is the gap. Why are people not hearing about it still?
What are, you said you hypothesize there are some, beyond just awareness of the program, there's some barriers to participation. What do you imagine those might be?
I believe it might just be language, as well as Mexican or like Hispanic community. They're not really that tech savvy, and also a lot of them are scared of public charge, and so I expect those to be the reason people are holding back. Or if they do know, maybe the process of applying is just too confusing for them, and so they just bother not applying at all.
This last question for me is, so it looks like you get to follow this study into 2024. Are you able to contribute to the manuscript as well? We have a whole 10 minutes, 9 minutes. We're just cruising through. Welcome, everybody. Thank you so much for being here today. We're going to start the next presentation, and I'll have. Oh, the windows are opening. Let's just let them do it. It's regulating our temperature. This building eludes me. So, Avneet, whenever you're ready, whenever that stops, you can take the floor.
Hi, everybody. My name is Avneet Sidhu. I am a rising senior here at PSU. I'm a part of cohort 2 of URISE. And this past summer, I have been fortunate enough to work with Dr. Stephanie Wahab from the School of Social Work here at PSU. And I'm super excited to talk to you about our new pilot study, which is a qualitative exploration of the impact of the criminalization of sex work in the state of Oregon. So to provide you all with a brief history about like what the context of this project is and what the necessity of it specifically is, in July of 2023, so just a few months ago, the Oregon legislature voted to fund a series of 2 studies that were going to explore the impacts of the criminalization of consensual sex work in the state of Oregon. And although that there was positive legislative support, the governor decided to veto the budget item during the last week of July 2023, so just a few weeks after it was voted to be funded on, stating that this is something that the private sector needs to be conducting, which is very interesting and also very controversial considering that this is a public health study. So that argument was very controversial. And she also stated that there was a need for additional public discussion about the issue, which is also really controversial because it's hard to have additional discussion about this issue if there's not actual research or database for people to be going off of. So a colleague of Dr. Wahab at OHSU, who's Dr. John Snowden, and Dr. Wahab were tapped to conduct a study, which is a public health study that studies the impacts of criminalization of sex work in the state of Oregon, particularly with attention to the impacts on gender and racial minorities, as well as other marginalized communities throughout the state. Funding is currently not available for the study, which is why this pilot project is going to be minimal compared to what it would have been if the legislator had actually gone through and funded the project. But the hope is that once we have more funds, that way we can expand this project and potentially gain access to like more knowledge and qualitative assessment that will benefit like additional research going down. So a brief overview of this project. The aim of this pilot study is to conduct a exploratory qualitative study that's going to better understand the impacts of criminalization of sex work, specifically within the Portland, Oregon region. Specific questions that we'll be looking at to ask individuals are going to be about how people in the sex trade experience criminalization of sex work in the city, in Portland. Potentially, what are the benefits of the criminalization of sex work in Portland, as well as who are the specific people that benefit from this and how they benefit from this exactly. We'll also be asking about the disadvantages and the harms that come from the criminalization of sex work in Portland, and who the individuals are that are specifically harmed and how they are specifically harmed. We'll also be looking at how criminalization can potentially help or hinder anti-sex trafficking initiatives, as well as the costs that are associated with the criminalization of consensual sex work in Portland. Our specific objectives, we will collect new and existing data that is going to be included through individual interviews with people who are involved in the sex trades in the area, as well as publicly accessible recordings that are available through the Human Rights Commission public hearing that specifically focus on the criminalization of sex work in Oregon from July 15th, 2021. We aim to get a better insight into how criminalization specifically impacts workers, whether it benefits them or if it harms them, and the other community members as well who can be impacted by this specific legislation as well. Because I'm sure, as you all are aware, laws, even if they're targeted to specific communities, rarely ever impact solely those communities. And we're really interested in like what the ripple effect also is here as well. We're really interested in also learning about like the lack of protections and recognition, because as you all are aware, if you're engaged in like illegal forms of like trade or work, you don't get access to like union benefits or any other like benefits that could potentially come from the government, including legal protections. So a lot of sex workers, for example, will be very hesitant to report crimes that have occurred against them, whether they're sexual battery or other forms of violence, because they're afraid about the implication that comes from disclosing that they have been engaged with a form of trade or work that is criminalized and the potential consequences that would impact them as well. So we're really interested in like what this lack of recognition and rights and how that directly also impacts individuals that are engaging in this specific trade that has been criminalized. Our specific methods will be conducting potentially 1 or 2 focus groups, as well as individual interviews of about like 8 or 10. Study participants are going to be recruited into the study. They'll be of any gender. We only ask that they're 18 years of age or older, that they speak English with sufficient enough fluency to be able to be understood by the PI and our study team, which involves me and 1 other individual, as well as living and working in the Portland, Oregon region, because that's our specific concentration. And they will have had to be engaged in trading sexual services for material gains, other than just like dancing or stripping, which is a legal trade. So they wouldn't be impacted by our study or applicable for our specific interviews. And they have had to do this work within the last 2 years specifically. The rationale for recruiting these specific individuals is because these are the individuals who are most impacted and targeted through these criminalization laws. And specifically the criminalization laws that target forms of sex work that the study aims to like specifically look at. So our expected outcomes, considering that this pilot study has just begun, the governor deciding to veto the funding was like a really big roadblock for a while, because it was like, oh no, how are we going to go forward with this study? But we're really excited that this pilot study is going to go forward. So far, we've been doing a lot of work on like reading up on prior literature, focusing on like how we can ask questions in a way that isn't targeting individuals, does it raise like defensiveness or discomfort, and does it cause them to potentially disclose things that could lead them into some form of like jeopardy. So we've been doing a lot of background work about that. Our expected outcomes particularly include the impact on sex workers and marginalized communities that are engaged in the sex trade. We anticipate that the criminalization of sex work in Oregon may have adverse impacts, not even just on their well-being while they're engaged in the trade, but also outside of it as well, because of the social stigma that comes towards individuals who are engaged in this sort of work. We believe that this might also have adverse impacts on their safety and the rights of them, potentially leading to increased stigma and vulnerability that already exists in the status quo. Potential benefits or drawbacks, we hope to identify both advantages and disadvantages of this criminalization and shedding light on like who specifically benefits, and most importantly also like who bears the brunt of that cost of that policy. We're also really interested in anti-sex trafficking initiatives, so our research might reveal insights onto like whether criminalization either aids or hinders anti-sex trafficking efforts, which could allow us to draw preliminary conclusions between the relationship between these two. And as well as potential economic and societal costs, we aim to estimate the economic and societal costs that are associated with the criminalization of sex work, and providing a foundation for future economic assessments for other studies that are willing to look into like who criminalization impacts specifically, who are the people that are forced to like bear the brunt of that economic expense, and who it actually comes at the expense of. So these are future implications that we are hoping from the policy specifically that the study will impact. We hope to be able to reform policy and advocacy by gaining a better understanding of whether criminalization has direct benefits towards marginalized people or if it harms them more so. We hope to better public awareness and education. Oftentimes the stigma that a lot of people who are in the sex trades experience is because of the misinformation of individuals who don't know anything about that industry and the people who are engaged in that work. Oftentimes people will like talk about individuals who are engaged in the sex trade very dehumanizingly, because these are individuals who bear almost like a second-class status because they don't have access to legal benefits and rights, which means that even individuals in like their day-to-day language will talk about like prostitutes in a very dehumanizing way, which definitely contributes to the social stigma. We hope to better inform training, whether it's for community partners, law enforcement agencies, or even healthcare professionals who are interacting with sex workers, as well as future comparative studies and longitudinal research that could potentially look at the work that we are putting out to get a better understanding of what laws specifically targeted towards criminalization have done to impact individuals in the Portland region, as well as the intersectional analysis of demographic data that we're hoping to collect of who are the individuals that are most impacted, what are their specific demographics, and why do we believe that these demographics are being impacted the way that they are. Gaining a better understanding of this will help us to gain a better understanding as to why the sex trades can function the way that they do, especially with the individuals that they can commodify and oftentimes even leave marginalized. So this intersectional analysis is really important because the identities that you possess and the privileges and resources you have access to completely impact the reality that you experience within the sex trades, not even just in Portland, but like the world as a whole. And this could potentially be good also for international comparisons. There's, if anybody's unaware, there's a specific county in Nevada that allows for regulation of sex trades. So they have what they call brothels within like certain limitations and rules where they allow for them to legally conduct business. And there's not really a lot of study that looks at the qualitative impact in Portland, Oregon. So we're hoping that our study will also impact other regions in the United States or also in the world that are looking to maybe alter their laws and provide different protections towards this demographic of workers. I would like to thank Dr. Stephanie Wahab from the School of Social Work for being a phenomenal PI. I'm really excited to continue to work on this project with her going forward, as well as all of my peers and everybody who's provided me support within Build Exito and URISE. And I open the floor for any questions.
You said that you didn't get funded. You just said the main barriers to really make you study because you're working in policy conversation, yes, as there. So then you also talked about so then is the public perception actually like if there's a shift in public perceptions with the legislature.
Yeah. I think that's a great question. I think it would be a misnomer on my part if I said that public perception didn't impact the study whatsoever. I actually had a conversation with my PI once we submitted our IRB, where we learned that Portland's PSU's IRB only conducted a thorough, full review to like the top extent that they do for 2 studies in the previous year, and our project was going to be one of them. So we had to be really meticulous about the language that we used and the way that we wrote up the IRB because of the specific population of individuals that we work with. Stigma and taboo does jeopardize and impact the way that research is conducted, and even the way that like research findings are corroborated. So I do think that public perception definitely impacts the way that this project is perceived and the way that other individuals and community partners might be able to impact and like help us out as well.
I'm curious about the process of developing questions, the interview protocol, and some of the things that you're sort of hashing out, because it's clear that you're planning to have the most tell me about that process. I don't want to make too many assumptions.
So Dr. Stephanie Wahab actually has a lot of experience within doing advocacy work as well as other community partnerships with people who are engaged in the sex trade in Portland. So she has a lot of experience with like doing work that is very inclusive to different communities, especially because they've been doing this work for a lot of years. So they have experience with like the way that you ask questions that are open-ended, and they don't necessarily make assumptions because targeted populations of people, like we talked about earlier, experience a lot of stigma and like miscommunication about like what they actually do and what their lived reality actually is. And every single person who engages in the sex trade is in it for a different reason. They experience a completely different reality. So a lot of our work and the way that we formulate these questions comes from previous studies that have been conducted that specifically work with people that are doing this work, as well as like our information also, so like how we can do this work in a trauma-informed way that honors the lived realities of people who are involved in our study without making like assumptions or potentially asking questions again that could jeopardize them or their safety. So we put a lot of time and effort into creating this interview guide that is hopefully going to be like the most equitable and robust way that we can conduct these interviews.
Maybe I missed it, but how are you actually going to get
Yeah.
You talked about the criteria, but you didn't talk about.
Yeah, there's a couple of advocacy groups throughout Portland that Dr. Wahab is involved with and that they have a partnership with through the School of Social Work that we'll be specifically engaging with. And a lot of these groups are like specifically targeted towards racialized minorities. So like Black and brown people who are engaged in the sex trade specifically. A lot of these individuals are already involved with not studies, but like advocacy work that specifically targets sex workers to provide them with some sort of like resources or like any other supports that they need. So we're hoping to first send flyers and like recruitment materials to those individuals. And then if we are not able to recruit like 10 participants from those individuals, then we'll expand to like broader community networks and then by word of mouth, because there are advocacy groups in Portland that do this work ground level, and they're going to be a really big partner in recruiting individuals for us.
So you're gonna conduct interviews with people, right? And
Yes.
see who's funded.
Yep.
How many people are you hoping to interview?
In our first set of interviews, we're hoping to get at least 10 individuals within the first advocacy group that we reach out to. And then if we aren't able to recruit enough members from there, we'll go and expand outwards. But 10 is like the minimum that we're hoping for. And then any other individuals would be like a benefit to the project.
What's the funding future? Will this go up in the next legislative session to be passed and then potentially vetoed again? Or was this kind of a one-shot opportunity to have it, in the state budget?
Yeah, that's a great question. There's definitely like future hopes for this to be included within the state budget moving forward. The hope is like the assembly, like in the future, would potentially include this in their budget discussion, but that's not necessarily like what we're aiming to hope for, because we do see that the stigma and controversy surrounding like this specific research does provide a lot of like temperament to the way that we can receive funding. So we're hoping to either access like other grants or resources that are available to us and not necessarily depend on the legislator to fund the project. Because right now, Dr. Wahab is bearing the brunt of the cost of this project, but at the time, we're not really focused on like additional funding until we like expand the project and are involving more people for recruitment. And then if we need to pay more individuals for interviews, then that'll be when we like assess the option for more funding.
So with that said, are you planning to pay participants?
Yes. Currently, the plan is to pay participants like $25 for the interview. That won't last even up to an hour. But we acknowledge that like $25 is not a lot to be talking about like trauma that you have experienced. We really are limited with how much we can compensate individuals. But also I would argue that like there really isn't a specific dollar amount that would be enough to compensate someone for the work that they're doing for us. So $25 is like where we're starting, also knowing that like the financial limitations that we have because the governor vetoed. Thank you.
Great, so you can either use this in advance or. Look at that.
It always happens. Actually, I'm not even, I'm just kidding.
It's
ready for technology.
You want to use the arrows?
Yeah.
Okay, yeah, they're ready to go.
Are you cool with showing yourself in the presentation? Okay. Okay. Okay, everybody, we're ready for the next presenter. Hi, I'm Kaisa Holt. I'm a senior at the OHSU at PSU School of Public Health, and I'm in the social science hydrology lab of Dr. Melissa Hacker. And so I just want to say this is environmental science management, but I was allowed welcome to the lab because we focus on the social, including the human dimensions of water in Oregon, and access to water is a human right, it's a public health issue. So my specific study in my lab is the water values of well users in Mosher Valley. And it's a survey of getting public perceptions and their sort of latent water values on what on their water needs, so that we can use the analysis and data for the Watershed Council to inform local government and future policy for future water. So Mosher, Oregon, it's a small agricultural community, just maybe 10-15 minutes east of the river on the gorge. It's when the gorge starts to get really dry and arid. And so they're on the river, but their main water source is it's a Columbia River basalt group, which extends up into northeastern Washington, and it's an aquifer of really good water. But and the major use of the water for irrigation, because Mosher is a highly agricultural community. So in the 70s, it was noted that alarming drops of water began happening since the 60s due to overpumping. So this prompted USGS studies to understand why. So there are studies that were conducted between 1988 to 2018, trying to understand why the water levels are dropping. Because if the water is gone from the aquifer, then they have no water, and people continue to move into this area. So it's an issue. So with the USGS studies, they measured actual water drops, which is 200 feet each year. So 24/7 water was leaking. They didn't know why, and then they found out that it's due to commingling wells. So commingling wells, the historical construction of these wells were created with porous boreholes, which is the tunnel that goes down into the water table to bring the water up. And it was leaking water where the water was leaking out above or below the water table, but it was leaking out into the streams, into the river, never to be found again in the aquifer, because usually water is restored back into aquifer to be used. That's hydrology. And so just to further illustrate, okay, so here's the hydrology, and then here's the human dimension aspect. So then just to illustrate, with the commingling wells, the water, they found on the fault lines from prehistoric earthquakes. So you'll see here, this is where there are fault lines from the earthquakes. And then on this map, the red lines show where the fault lines are. And that's where most of the water leakage from the wells. And so the red dots are the wells. And so you can see all the red dots on the fault lines. So that was contributing to lots and lots of water loss. Okay, so that's the end of the hydrology part. Now to human dimension. And so my specific study, I did a survey to get what well users' values are on water are, because they had federal fundings to replace these wells. But some people were replacing their old wells and a lot of people weren't. And the Mosher Watershed Council, they didn't understand why. And in my lab, we understand in different communities it's because of mistrust of government, or it's the cost associated, where they just couldn't disrupt their work to have an intense construction done. So I did the survey, and the specific survey that we use is a really interesting method called Q-sort, or Q methodology. And it's sort of, I consider it qualitative, but it gives you hard data. So it's a survey of statements. It's not questions, it's statements that people can, they end up ranking and sorting. They answer this, they rank the statements on scales of, highly disagree, don't disagree at all, or they check as many statements that apply. And then at the end, I'm gonna come back to this, but I'll just show you. But at the end, oh, it's not on here. Oh, it is, it's here. Okay. And then at the end, they'll take their statements and then they rank and sort it themselves from disagree to agree. And what that does, it's really interesting, is that it investigates their perspectives, and then it also pulls out latent social discourses. So even statements or even perspectives that the participants would have, like I can't explain it in the most scientific way, it's really cool though, but it formulates it in a way, and it can group them into different groups that for the qualitative coding, you can name them either for our lab, it's either the libertarian, people that think government should control water, or more indigenized thinkers thinking that water is more spiritual, or that the city should pay for water, nobody should pay for water. And so it's really interesting. And if you have more questions, I'll do my best to answer it. But Q-sort methodology is really good, getting perceptions, in order to inform how to get funding or sort of facilitate infrastructure uses. So this is my results, but since my study is not done yet, I don't really have results. So I just showed you a little bit of my analysis for half of my completed survey. And I just wanted to show you, okay, so this is an example of one of the questions. So one of the statements on my survey was, overall, the quality of my drinking water is good. And then they rank it from strongly agree to strongly disagree. And it's really to get a better understanding of their water values and their needs and their situations. And then here's another example. Where they can just check as many that apply. And this is specifically in the Mosher Valley where they use well water for rural irrigation. So here are the statements that they can check. I have running water in my home with fewer disruptions to, I mostly use boiled water. And this is actually the survey that we've used all over Oregon. So it's just pretty standard survey that we have. And so there's the Q sort. And so lastly, the significance of this, like why in this small town are we doing this water values? And I know why, because they want to know why is nobody using these funds to replace their wells. But worldwide, in Oregon, all over the country, in any sort of complex issue, the understanding between the interplay really of public needs, what they think, what their values are, their perceptions, their perspectives, that actually has a direct influence and an impact on what policy comes through and what the local government does. For example, in other parts of the world, I think in Iran, places where they've experienced a lot of poverty and environmental devastation, they perceive themselves as highly resilient because they are highly resilient. They've had to live through a lot. And so in the surveys, they come off as very resilient. So the government's like, okay, they're not asking loudly for new infrastructure. We have to balance our budgets, so we're just going to put this aside. That's a really overarching example, but it really kind of works out that way. And there is a good amount of research, but it's still really low in this area. And it's just interesting to me because perceptions and perspectives in your body, some public health in your body, it's real because it affects your physiology, but then the interface, when it comes out and you talk about it and you vote about it, it's not really a fact, because I say this with the most respect, and I do this too. Perceptions are often misperceptions, and we're voting that way. So I think that's, I like Q-sorts and I like public perception surveys. And so specific to my study area too, Mosher Watershed Council, they want to replace these wells. They want to ensure water, and they want to ensure future water supplies for future generations, which is pretty amazing. And so having this data and understanding how people work and how to give them information or deliver information in a way that they can feel and understand, it can also give not only hope, but actual agency in order to ensure future water supplies with this information. And that's the end of my presentation. Thank you very much. I'd like to thank my PI, Dr. Melissa Heffner. She's wonderful. My lab, Psudo NIH, and the Mosher Watershed Council. Thank you. Yeah.
I have a question. Can you go back to the example statement?
The first one or the?
Yeah, this one's okay. How many people answered that?
I only had, okay, so 6. So for a Q-sort methodology, you can have thousands of people, but I only wanted 12 to 15. That's why Q-sorts are so cool. You don't need that many people, but there were some things that have some little small town politics. So this was 6 people. Yeah, as you can see. Yeah, very inclusive study now.
Thank you.
Okay, so the commingling wells are the problem for the decreasing water levels in the aquifers.
Along with overpumping, but mostly the commingling.
Okay, but the real solution that is being proposed here is replacing these wells. Is there conversation about that not being a sustainable solution for the decades or centuries to come? And the overpumping.
Okay, so the overpumping, they are using, so I didn't look into all of their different irrigation, but there is water saving irrigation methods that they're using, and can't give you all the specifics, I just haven't looked up. But And then the code, that's a good question, because yes, and I'm curious now if there's something better. But yes, that's the only thing with the USGS studies, the Watershed Council, the irrigators, and the federal funds, about the Mosher millions to replace the wells. That's the best. And I don't know if it is the best, but I know in other places, where in New Mexico, where their water is pretty good compared. I mean, here you think we should be pretty good at water, we're not. But in the Southwest, they're doing good with their water sustainability, and it's all PVC. So as of now, as far as I know, it's the best. Well, that's what they're operating on this. It's a good question.
Yeah, I think I just have a clarifying question of that there are some people who are, I'm just so curious about this taking in and like checking in with your body, like you know, but that's because I also like, you know, in practicing like how information sits within ourselves and then what that information is that we detect here and how does that connect with our actions, because there can be such a disconnect between what you actually feel and what you do. And I think that was interesting that you brought that up, like that it is not always maybe there are other factors that are making people not choose to like work on the wells, you know, because they, like maybe some people in their community are like, oh, don't do that, and they go along with popular opinion, or there's not enough information. But and I think you also brought up the point that the if you don't tell the government that you need stuff, that you're in need, they're gonna think, oh, well, you're fine. We won't get the funding.
Well, the government, they don't know, I don't know exactly how the government works, but all the literature and whatever, I'm gonna say this in very lay terms. What I understood, and from my lab, understanding how policy, how it's complex it is, and balancing and all the stakeholders. So with that, just to clarify that the government isn't that, oh, you don't need it. The government's like, we can put this aside for now. They need it, but these people are really loud, because then it's again, right, with the needs thing, they're not gonna get the funding because it's like maybe the public, they want more, because a lot of government legislative politics, they need people to vote for them. So they kind of got to do, I mean, I don't know if that's but it's like that. It's not like, oh, they don't need it, we're not aware. I think there is an awareness of this population or community needs something, but they're like, oh, thank God, they're not fighting for it. So we can pay attention to the other stakeholders that are speaking really loud, right? I don't know if that's bad to say, but
yeah, it's complicated.
Yeah. And then the public perception, when it is a fact in your body, just because it can make you mad, or it can make you, you know, so in the it's a fact, right? Like if you don't trust the government makes you so mad, you're gonna feel that, and it's gonna have a biophysiology physiology. But then if you're like telling a class of people that the government's bad and don't trust them and don't use these funds, then it's you're operating on these perceptions.
So these funds are free and available for people to use and replace their well?
Yeah, so there's funds, there's funds, but there's also, it's a matching. So there's funds from the government, federal funds, and then there's funds from the city and from Oregon, state funds, and then also, unfortunately, the well users have to put a little bit more too. And since this is the government, it's a government contracted project, then they have to go through those specific and it's a little bit more expensive. So I think that's the thing as well. The Mosher, my community partner, was thinking, I think people don't really trust the government. We don't know why people aren't doing, but his one thing is like, I don't think they really trust the government. I don't know, because that's quite common actually in Oregon, with water infrastructure and prevention mitigation. But I think that it is just, I don't know, again, I think it's just the cost. And also, I mean, they need their water, like it's going to be really disruptive, you know, to their work. Yeah. So they talk about the Mosher millions, but it's actually, you know, a lot of money from different sources.
I'm curious, have you considered looking at the demographics of the people that you study?
Oh, yeah, and on the survey, of course, right, because I'm social science, like 2 pages are demographics. And so most of the question, you know, of course, skin color, education, income, job, yeah. So these are mostly white people. Yeah.
Thank you so much. One here presenter today in this room.
Notes you need to look at. Great, no, that's great. Just want to make sure you weren't see something. Yeah, we're right on schedule. So are you cool with introducing yourself? Okay, great.
Hi, my name is Alejandra Nuñez. I am a junior here at PSU. I'm in Dr. Blair Darney's lab alongside Nancy Ledezma. This summer, I conducted literature review for my lab. I'm currently researching health literacy in the Oregon Latino population. This is a work in progress. So firstly, what is health literacy? The US HHS defines health literacy as the degree to which individuals have the ability to find, understand, use information services to make informed health-related decisions. Other forms of health literacy include organizational health literacy, digital health literacy, and numeracy. However, I'll be focusing on one's personal health literacy. The impacts of health literacy include fully understanding one's diagnosis, directions, brochures, following the provided physician's instruction, seeking out medical care early, making informed health decisions, unknowingly consenting, access to preventative care, and there's always a risk of misinterpretation during communication. These are 3 health assessments of health literacy that I've discovered while doing my literature review. The first one is REUs, standing for Rapid Assessment of Adult Literacy in Medicine. Second one is STOFHLA, Short Test of Functional Health Literacy in Adults. Lastly, the SAHL-SME, which stands for Short Assessment of Health Literacy, which is in Spanish and in English. And then there's photos, examples. The first one, REU, assesses one's literacy based on their ability to pronounce medical terminology. An example of this would be the person that's conducting it, asking the patient to read aloud the word list, and they try their best. If not, then they have the option of saying blank. The estimated time for administration of the REU is 5 minutes. And then on the bottom is the grade equivalent that one would get from their REU score. Second one is the STOFA. This one measures comprehension, including the ability to read and understand. There are 4 numeracy items and 2 passages with a total of 36 closey items, which is shown on the bottom right image where you fill in a sentence. The estimated time for this administration is 7 to 10 minutes. And then there's the scoring of the health literacy on the bottom left. Last one is the SAHL-SME. This one is comprised of 18 test items that test the ability to read and understand common medical terms. This is conducted with flashcards, and the patient is asked to compare the 2 words to which one correlates to the initial word. The estimated time for this administration is 2 to 3 minutes. And for example, the image on the right has terms in Spanish. And for example, the first one, you'd have the word empleo, which means like work in Spanish. And you have to associate it to either
work or empleo, worker, trabajo, work, and then education. So you'd correlate which one makes more sense. So test comprehension. The correct answer for each test is determined by the pronunciation and the accurate association of the word. And the score between 0 and 14 suggests that the examinee has low health literacy. From this, I gathered that the SAHL Spanish and English would be the best for our demographic, as we will be recruited in a Spanish setting. This assesses the individual's reading skill in the healthcare context. It's also comparable since this test is offered in Spanish and English. And the administration would take 2 to 3 minutes and requires minimal training. So the next steps for me in this lab is to develop and finalize my objective and hypothesis. Then I will develop a survey utilizing the SAHL Spanish and English assessment. Then I will submit to the IRB, and then I will be able to begin recruitment at the Consulado de Mexico. And then on the picture on the right is the waiting room, which is where we do recruitment in downtown Portland. Thank you. Any questions?
Back to that last, the survey in Spanish, the essay, that one. It's interesting because if you're a Spanish speaker, an infection could kill you, and it could also be a virus. So, you know, it depends on like this kind of survey. To me, would be confusing, and so I'm curious how it will play out with Spanish speakers, depending on their literacy, like how do you compare literacy and just either education level or even where they're from in different parts of Mexico. Like there's a lot of variables in this study. So how do you prepare for these kinds of questions or
like one's comprehension of the, actually, as I was doing the literature review, that was a common issue that a lot of Spanish speakers come from different origins, and so there's different variations of the language. But out of the ones I researched, this one is the one that has the most like reviews and like a general pool of usability of comprehension and like being able to associate terms. Yeah. And I also conducted this one on my dad and my mom, and my dad has education from Mexico. He went to school there, but he didn't continue education. My mom went to high school here and she completed high school. And there was definitely a big gap between those two. Yeah, it's interesting to see.
It would seem like that the scoring of this would just bring more complexity potentially, but then also tell, say, a health practitioner where they need to be more specific. Is that one of the reasons that this survey exists, to show those gray areas, do you think?
Yeah, there was also another part that I was reading was how one would want their like, information to be relayed in terms of like brochures, if they want that verbal, audio, like physical instructions, stuff like that.
Yeah, it just seems like more variety of ways to talk about the thing in question that's happening with you in a health context. Yeah. Cool.
That's a question.
This might be out of scope, but one of the things you pointed out was that you chose that instrument because of the population. Many of them are Spanish speaking, right? How does this play out in the language that's used when individuals are interacting with practitioners or clinicians? You know, so is it sort of just making this assumption that their care is going to be in their native language? Does that question kind of make sense?
Yeah, it does make sense.
Because it's like comprehension of these things in Spanish versus English or both is really different. Is there anything like any conversations like that come up in your lab?
I think there's definitely conversations, but I think that would kind of relate to like more
are they able to like understand their prescriptions, the instructions? Because I know that someone previously in the lab dealt with concordative care of like if they have a translator, are they like getting the best out of that service?
Got it. So it's more about in the language that they're reading things in and hearing things in. How is their understanding? Yeah.
Thank you.